Welcome to the March Coffee with a Clinician. I'm Clayton Powers and I'll be facilitating today's discussion. I'm a doctor of physical therapy specializing in the care of individuals with complex health conditions. I'm also the education liaison at Bateman Horne Center. Before we begin, we want to thank the donors whose support makes our community programs like this possible. For this session, Larry Baldwin and Staci Stevens will discuss the first two sections in Chapter 4 of the Clinical Care Guide titled Post-Exertional Malaise. We'll discuss the key characteristics and pathophysiology of PEM and answer other questions that participants have in the Q&A feature. Unfortunately, Todd Davenport was unable to join us this morning, but he'll be joining us for our May session. Future sessions will address additional aspects of post-exertional malaise, such as testing and management. And as a reminder, we cannot provide medical advice. So I'd love to introduce our panelists today. We have Dr. Larry Baldwin. He's a medically retired general surgeon, and he's lived with ME/CFS for 31 years. And he's currently working on research to understand the pathophysiology of PEM. And then we also have our esteemed guest, Staci Stevens, and she holds a master's degree in exercise physiology and founded the Workwell Foundation to help patients obtain objective evidence of PEM for disability purposes and to research how exercise contributes to PEM. So we'll start with a poll. We're going to two-question poll for everybody attending. And then at the end of this, the presentation portion, we'll end the poll. So they'll share the poll now, and then you'll have plenty of time to fill it out. It's only two questions. And I'll go ahead and share my slides. So as I mentioned, we'll be talking about the characteristics of PEM and the pathophysiology. And we just have this disclosure about Bateman Horne Center that no specific products, medications, or other things will be promoted or endorsed during today's presentation. So this Coffee with a Clinician, the content comes from the Clinical Care Guide, and there's a QR code to look at it. This is a great resource that the Bateman Horne Center put together to be able to share with your healthcare providers and others so that there are options for how to manage the symptoms. We'll be talking about Chapter 4, which is the Post-Exertional Malaise chapter. So post-exertional malaise is a cardinal feature of ME/CFS, and it represents a distinct pathological response to exertion. It's different than normal for fatigue or even post-exertional fatigue. Like if you go exercise and experience fatigue afterwards. Post-exertional malaise is different than that. It manifests as a multi-system deterioration following minimal exertion of different types. Here are some of the characteristics. There's a delayed onset, often appearing 12 to 48 hours after, and some people even 72 hours after. There's prolonged recovery, which typical recovery for most people from exercise, even maximal effort exercise is most people recover within 24 hours. And this post-exertional malaise, it can persist for days, weeks, or longer before returning to baseline, and in some cases doesn't return to baseline. And then multi-system manifestation, I'll talk about on the next slide, but it affects multiple areas of the body. Also, there's a disproportionate severity. So when you exert, there's the response, the body's response is more severe than from typical exertion. And then finally, there can be a lot of different triggering factors that affect post-exertional malaise. So we'll touch on that multi-system manifestation. So it affects multiple areas of the body, including cognitive function, concentration, memory. It also affects the autonomic nervous system, so regulation of blood pressure, heart rate, temperature, and so much more. It also affects the immune system. So often patients will experience flu-like symptoms or lymph node tenderness or other symptoms when they're in a crash. Some people will get a sore throat or I feel like I'm getting sick. And then neuromuscular function as well, including muscle weakness, pain, and a key feature of ME/CFS is unrefreshing sleep or unrestorative sleep. And for the pathophysiology, one of the main things that we find is impaired aerobic energy metabolism, and then neuroimmune dysfunction. So post-exertional malaise is characterized by a difficulty producing energy with the aerobic energy system. And our body has a few ways of making energy, but the main way is aerobic energy production, and that is affected where the body can't use oxygen effectively. And then there's also been research looking into mitochondrial dysfunction, and people tend to go into anaerobic energy production sooner than normal. And then as far as neuroimmune dysfunction, there's signs of inflammation with exertion, including neuroinflammation, so inflammation of nerves, the brain, spinal cord, and then autonomic dysfunction that can impair blood flow and oxygen to tissues. One of the studies that's just came out showed that after somebody has exerted and it's in a post-exertional malaise episode, that there's impaired blood flow to the brain, even when laying down on a bad day. And then other disturbances to the body's ability to create energy. Part of the pathophysiology of post-exertional malaise is that there's a reduced blood flow to the brain. In studies by Van Kampen and Peter Rowe and others, what they've shown is that individuals with post-exertional malaise or ME/CFS, when they were on a tilt table, so it's tilted at 70 degrees, and they were there for 30 minutes, they found there was a 24 to 29% reduction in blood flow to the brain in the patients with ME/CFS. And what's surprising is that about half of the patients had normal heart rate and blood pressure during the testing. So if their doctor was looking at their blood flow or their heart rate and blood pressure, it would be normal. But then when they actually test blood flow to the brain, it's reduced. And then even in sitting, when they measured blood flow to the brain in a sitting position after 1 hour, they found that individuals with ME/CFS had a 24.5% reduction in blood flow to the brain. And so this is part of the pathophysiology. So PEM is not simply fatigue or deconditioning. Now Dr. Baldwin will share a few slides. He's been doing research for quite a while on post-exertional malaise to try to figure out what is going on and in the body. All right, I'll turn the time over to you, Dr. Baldwin.
Okay, thank you. Well, Clayton, you did a very good job of describing an awful lot that's going on. And my point for putting up this metabolic pathways slide is that things are complicated, and that in the process of doing an exertion, quote unquote, an exertion, the thinking and or the physical movement actually elicits the beginning of a process, and of these many chemical reactions, molecular reactions, and cellular recruitments. Each of them takes time, and so I'm focusing on explaining why there is a delay, and that I'm hypothesizing that if the delay is figured out, that that will aid the figuring out of the post-exertional symptoms worsening, and that will help figure out what is causing the disease in the first place. So let's look at the next slide, please. So I have just a conceptual architecture here that there is an inciting event, whether it's infection or car accident and that there is a delay of biology, and many of the things that are happening, Clayton described, involves the immune system, and involves the metabolic system, that involves the neuroglial immune system as well. The gut microbiome gets a modulatory effect there. It can make it worse, or it can make it anti-inflammatory, and the hypothalamus pituitary adrenal axis can also have modulatory effects. So the gut wall is a layer of mucus. It's a very important layer of mucus, and then there's a one-celled layer of gut lining cells, and then behind that a protective layer of immune cells that are trying to keep any microbes that are trying to slip between the tight junctions controlled. But some of them will get through all that. They will work their way through the liver, which is going to be another filter, and eventually get into the bloodstream and get up to the brain. There are also other ways that the gut positively influences the brain. And the blood-brain barrier, the barrier that keeps bad things out of our brains, can also have problems. But the thing I wanted to show on this slide is that blue box where the gain, like dialing up the gain on a microphone, and it starts to do that squelching and clipping sound, that is happening. And I show a red outlined box of reinforcement, and that is showing that the dampening anti-inflammatory effects of the cells and the body aren't working as well. So you have things, sensitivity turned up, and you have the modulatory effects turned down. And that is part of what we patients are experiencing. Next one, please. This is just, don't bother reading everything other than the big black letters. This is part of the core immune metabolic program. The word program is used so that specific molecules aren't the focus, but rather families of molecules as far as doing research, and that there can be multiple proposed metabolic abnormalities, and people have heard of IDO, the immune, or the imidoamine 2,3-dioxygenase pathway that leads to the kynurenine pathway. People may have heard of that. Also, people may have heard of the itaconate, the interferon alpha induced in itaconate shunt. And these are candidates. They're not saying that these are specifically validated, but regardless, abnormal metabolic pathways to creating energy are less efficient and actually sometimes are destroying the high energy molecules that we need. Next one, please, Clayton. There is a neuroimmune, meaning the nerve cells themselves communicate to their immune related cells, and those cells themselves can also release a whole host of molecules that are symptom causing, and one of them is the microglia, kind of one of my favorite focuses, and that those microglia are in an abnormally hyperactive state, and they don't abnormally, and part of the disease is they do not return to a normal healthy state, so that they're always hypersensitive and don't perform their function as well. Next one, please. Like I said, the gut microbiome ecology is abnormal in people with ME and long COVID, and that is not a good thing, because the gut microbiome produce a lot of the neurotransmitters that we need for leading a healthy life. But also, like I said, the microbiome microbes, if you counted them, they actually outnumber the cells that are what we consider the body by tenfold. And so they are an important part of having health, and they also contribute to disease. Next one, please. This one I'm trying to show, actually what I'm focusing on is what is causing the delay of the onset of the post-exertional symptom problems. And the main part of this is that collecting samples earlier after the either some things that we do cognitively, cognitive work or physical work, but collecting samples soon after that process is done in the laboratory, I think is important to be able to figure out when PEM starts. So I know that there's collection of samples 1 day after and 2 days after, and maybe 12 hours after, but I'm also advocating for something sooner in the 0 to 2 hour or the 12 to 12 hour time periods. And then the next one, I think that one, we can go back to questions that you have, and I'll talk about this later.
All right, we'll stop the sharing. And we're going to end the poll. So looking at the poll of how long after activity does your symptom worsening typically begin, it looks like there's a wide range for a lot of people about when their post-exertional malaise occurs, but generally there's a delay of 12 to 72 hours later, but it can really vary and change. And then once post-exertional malaise begins, how long does it usually take to recover back to your baseline? And I know that some people don't fully recover to that baseline after an episode of post-exertional malaise, but it looks like 54% of people, it's 3 to 7 days to return to that baseline function. So it varies, but it looks like there's usually a delay, which is part of the characteristic of post-exertional malaise, that there's this delay, and then it takes longer than normal um, to respond to exertion. So we'll start with the discussion now, and I want to first hear from Staci. Staci, have you've lived with ME/CFS for quite some time. How can someone figure out the signs and symptoms of post-exertional malaise that they're experiencing?
I think it's the most perplexing and disabling symptom. And for myself and my group, we've been doing nothing but discussing this and researching this for the last 20 years. So we meet every week and we're still discussing it. Dr. Baldwin, what a great hypothesis presentation, because the bottom line is it's complicated. It's hard. It's perplexing to figure out. And so, one of the things that we've done is we have employed a standardized exercise stress. As an exercise physiologist, this is what we do, a cardiopulmonary exercise test. And then we like to ask the patients, how did you feel? How did you feel immediately? How did you feel the next day? How long did it take you to recover? And so we want to know what the patient experience is. We're not going into this blindly. We've developed, as a result of a bunch of these 2-day cardiopulmonary exercise tests and these open-ended questionnaires, we've developed a time course. And I used to think about the time course of post-exertional malaise in terms of short-term PEM and long-term PEM. And then a few years ago, I was sitting in Mark Van Ness's office and I said, hey, you know what? We're asking people how they feel immediately. And guess what? After exercise, they feel terrible. What? There's an immediate consequence of PEM. And of course, that immediate consequence, everybody experiences it on an exercise test. Healthy individuals have fatigue and shortness of breath at the end of the test when you can't go any longer and you're done. Uh, it's called a symptom-limited exercise test for that reason. And the symptoms are similar between patients and controls immediately. I call it fatigue, fog, and flu. This is the time course. People get really confused. I think it's so hard to manage this condition because there's so many symptoms and they're all over the place. In fact, from our recovery questionnaires, we found 18 different symptom categories, not 18 symptoms, 18 categories. There are over 100 symptoms, right? That's how do you figure it out? Well, we make it easy for you, or we're trying to make it easy for you. And every time I meet with a patient, this is what we talk about. What is your time course? And I have a recovery questionnaire if they've had an exercise test. I know how they felt immediately. So ask yourself, how do you feel immediately after you start experiencing PIN? What is that first sign or symptom? It's going to be something like fatigue, shortness of breath, maybe dizziness. If you really push, you might be nauseated. That's the immediate cause or the immediate symptoms of anaerobic metabolism, the metabolism that's inefficient without oxygen. If you can identify that and begin to understand that your aerobic energy system is broken, and you're not going to fix that through exercise or anything else, but understand that symptom, where it's coming from, that system is broken, then you can begin to prevent it. So ideally, you want to stay, your immediate is immediate, short term is 2 to 4 days, but now not only do you have those immediate symptoms, they start to build. So you get to have more. Sorry, that's how it goes. And the more is now you're involving uh, your neurological and cardiopulmonary systems in the body. So dysautonomia is flaring up. I call this the brain fog. It might be a little different for you, but figure what that is for you, because now your symptoms are shifting. If you're in 2 to 4 days, they've changed. So you've got the initial, but now you've got a few more. So it may be headaches, brain fog, cognitive problems, sleep disturbance. That's the cluster in the short term. If it lasts 7 days or longer, now you've built a little bit more. You're experiencing the effects of the aerobic energy system being broken, but now you've created a sustained immune response. That feels like the flu. You're on the couch. You may have other cardiopulmonary symptoms. This is the time course. So, what I recommend is that you identify where you are in the time course. What is the one symptom immediately that you experience? What is that first sign of short term? And then what is that first sign of long term? You want to stay out of the flu. You want to quit causing that chronic inflammatory response to the point where you're just going down, 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 and you can't get off the couch. Ideally, you want to stay immediate, right? Catch that PEM symptom, nip it, and then you can continue to plan activities throughout your day and week. That is the PEM time course, and I hope you'll find that a practical tool to really help you get a handle on things so that you can pace your activities better and understand what's going on.
Thank you, Staci. You also help a lot of people with proving to insurance companies and to their doctors that PEM is not just deconditioning or being out of shape,
Yeah.
and that graded exercise isn't going to help. Can you touch on like some of the ways that you're able to show that this is not deconditioning or being out of shape?
Well, that's why we developed the 2-day cardiopulmonary exercise test. And actually, I developed it because I knew I could not reproduce my exercise test results. I was, an undergraduate student in the Health and Exercise Sciences department at the university. We're all doing a lab. And I'm thinking, hey, I don't think I can do that. I can't recover. I'm in PEM. But the thing about this exercise test is its hallmark. It's known for its high reproducibility. And so I jumped on the bike one day and then came back 24 hours later and all my numbers were lower. This was not supposed to be possible. This is not possible. Heart disease patients and lung disease patients and Parkinson's disease patients and people with MS and HIV, they can reproduce their exercise test results within 24 hours. In PEM, that's not possible. The metabolic system is getting slammed. And so the results often come back lower. And there is a shift into very efficient aerobic metabolism into anaerobic metabolism. And you don't see this in deconditioned individuals. We test our controls for our research studies are healthy, deconditioned, detrained individuals. They come back and do the same thing. They say, I feel a little tired, or I feel better, not worse after exercise. And that's what I always come back to. If you don't recover from something, there's a problem. That's not normal. Things that make you feel good or used to make you feel good, if they make you feel bad, that's a problem. That's PEM.
And I hope you don't mind me mentioning this, but when you do research at Workwell, do you sometimes you are the patient subject that you do the
I'm the guinea
CPET
pig for everything. Yeah,
so that you can figure
absolutely.
out
hmm
things that can help and things?
I mean, I have others that are willing to sacrifice their bodies to help with the research. I'm so grateful to all of our patients that have participated in our research studies. But yeah, I'm often the individual that goes through it. Sometimes because I want to do the research and not be in PIM myself, I will ask some kind-hearted ME patient to come in and let me watch what happens to them. So we are
And
blessed with those as well.
yeah, it's unfortunate that we have to, in order to figure out solutions, it's sometimes requires like you are doing part of the research on yourself. Dr. Baldwin, you, as someone who's lived with PEM for 31 years, lived with ME/CFS, for patients who are newly diagnosed, how would you define post-exertional malaise in a way that's different from normal fatigue?
Well, Staci, I appreciate what you're saying about how to identify things, and actually to write things down so that you remember them, because there's brain fog afterwards. So it helps to have things written down that you're talking about as far as our own symptoms. But I would not use the word fatigue in any way in describing PEM. I feel that as a surgery resident, before the limited duty hours, we were averaging 120 hours of work on duty without break per week for the 3 months cycle, and sometimes 140, and one time 150. And I feel like I know what bone weary fatigue is like. In no way would I ever be able to guess what people with ME fatigue would be experiencing. It is just completely different. And I use the analogy of running in a marathon on a hot day. Some people might get obviously you get tired after a marathon, but some people might get heat exhaustion, and that needs to be taken care of. But some people get heat stroke, and if it's not taken care of immediately, people can have very serious consequences. And so I think that that's how I look at PEM, and the plans have to stop. Medication and activity has to be directed toward recovering, and if that is ignored, what I would call activity stacking or PEM stacking, like Staci, you're saying, it just gets worse and worse. And it's a real thing. I've pushed through in early years. I pushed through that PEM wall and got pneumonia trying to help somebody out. And so I know how dangerous it can be. And it's so important to heed these things that Staci is saying.
Yeah, it's challenging because of that delay. You had shown in your slides the number of biochemical reactions and processes going on in the body, and there's this delay, and so it can be really hard to know that you're going into post-exertional malaise without really recognizing those signs and symptoms early. Sometimes you do an activity and then 2 days later you start to feel those effects kicking in. Mm-hmm. Are there any biomarkers on the horizon that might help diagnose or monitor PEM?
Well, there are a good number of research studies that are differentiating with their research result patterns that can well differentiate people with ME compared to other diseases. But for a clinically relevant test, it needs to have high specificity, has to have high sensitivity, has to be affordable, or at least have people pay for it, and it has to be distributable, and it has to be easily performed or drawn in a clinic. And there are not things like that. What Staci, you do is an important part of validating disease, a very important part of validating disease, and especially the high number of people with this who are unable to work and maybe unable to take care of themselves. Getting disability is critical. And so Staci's program provides that.
So, in mentioning that, the Workwell Foundation, when you've done a lot of tests over the years with individuals who have ME/CFS to capture that PEM and to justify disability or accommodations for work or school or things for individuals. Is there a dose response relationship to the amount of exertion somebody has and the PEM severity, or is it kind of unpredictable how someone's going to respond to the test?
So I think that's the next question that we're going to answer, right? We provide that standardized stressor. It's a max test. But what's so interesting when I talk to patients afterwards, we'll go over their report and whatnot, is, I'll say, well, where are you in the PEM time course? And the majority of them are in long-term PEM. They're in the chronic inflammatory immune flu-like state. They're like, I just had a patient I talked to. They never feel better. They're like, I don't ever feel better because they're living their life in this inflammatory state. They're not ever resting. It's because the oxygen cost of their daily activities is above what they have available. And they don't know when to stop. They don't have that heart rate at threshold to stay under, and they have to take a shower, and they have to make breakfast, and well, you got to have coffee. The important things in life still have to be done, and they don't realize that that is living their life above their threshold, and nobody's designed to do that. And so that's the problem, I think, is people come to us, and unless they have a healthcare provider, Clayton, like you, to tell them, hey, you have got to back off so that those symptoms can calm down. It gives them permission to rest, is what it does. I'm like, here are your numbers. You need to stay under that heart rate at threshold. Taking a shower is above. So now taking a shower for you is like running a sprint. You can't run 50 sprints in the morning and then expect to function the rest of the week. So I think having, those limits in black and white is really helpful. And then you'll be talking about pacing at another time, but knowing where you are in the symptom time course and then staying out of that long-term flu-like inflammatory PIM so you don't get a pneumonia. People are still trying to work. They're still trying to live their lives. They've not given themselves permission to listen to their bodies, to listen to their symptoms, and to rest because everybody should be able to sit up for an hour. Everybody should be able to shower. Why should I not do that or change the way I do those things? That's ridiculous. Well, if your body's telling you that you're in PEM, then you're doing too much. Even at those very low levels, you might have to lower them even still.
Yeah, that's the part that can be so debilitating is um, that it really limits tolerance for activities
Hmm.
and daily life. And I remember I was treating a patient who he had undergone the testing with Workwell, and his resting heart rate was around 60, and his anaerobic threshold, or that level that he would be going into post-exertional malaise if he stayed there more than 2 minutes or longer, was only 85 beats a minute heart rate. And so that's really limiting, only being able to raise your heart rate 20 to 25 beats a minute. And so, like you mentioned, showers or other activities can be like sprinting. And after 50 sprints in a day, the body is just taxed and becomes inflamed. Um, and so, one more question about that: when you've tested quite a few or helped people with the disability testing, how long have you seen that post-exertional malaise can last, and what determines whether someone has a short crash
Yeah.
versus a prolonged
Yeah,
relapse?
sorry, I didn't answer that question
No,
for
you're
you.
good.
Yeah, so we've asked the question, and about half our patients, this is crazy. We've published this. I didn't believe this until I kept seeing it. 50% of our patients recover in 2 to 4 days. And I'm like, well, who is that? That's not me. The other half takes 7 days or longer to recover. And intuitively, I would think those that are the most severely ill, those with the lowest aerobic capacity or peak oxygen consumption, certainly those are the ones that are going to take longer to recover. And it's just not the case. Those at the lowest VO2 often recover in 2 days, and maybe it's because they're so low, they just can't go much lower, or, I would expect their PIM to last longer. It may have to do with duration of illness. So it doesn't seem to have to do with severity. And so That's exactly what we are really curious about. We don't know the answer, is the short version. What I tell my patients before they decide to do this or anything else that would cause PEM, like going to see your doctor or having a family gathering, is you should have an idea of what your personal time course is when you overdo. How long does it take you? You should have a clue. Um, and if not, start tracking that time course. If you don't know, and it's hard to know if you don't have good tools, start figuring it out. Are you, when you do something, do you respond quickly? Do you recover quickly, or does it take longer? And figure out what that is for you because nobody, you don't, Clayton doesn't want you in bed. I don't want you in bed for 6 months. I would love for you to have a 2-day window, go do it, live your life, do what you want to do, but recover in a day or 2 days. That's a great management strategy. That's a great way to live your life because it allows you to do things instead of just saying, don't do anything. Do what you want to do, but then pay for it. But try not to pay for it for weeks or months.
Yeah, activity pacing can be that balance of that activity and rest. And it can be really hard though. Sometimes people get into that what's called rolling PEM, where it just seems like it's really hard to get out of
Yeah.
that cycle of that push, less of a push crash and more of a crash crash, just
Hmm.
staying in that. And that can be really challenging to get out of. Often I find that needs additional medical support to kind of supplement and help to get out of that. Um, Dr. Baldwin, if you could correct one major misunderstanding about post-exertional malaise, one sec. While we've been saying post-exertional malaise, that's the term that's been adopted, but really it doesn't capture, malaise doesn't do a good job of capturing the severity. Post-exertional neuroimmune exhaustion or other terms do it better. It's just become kind of accepted to say PEM or post-exertional malaise, but it definitely doesn't capture the severity, the unpredictability, and all of that, and how widespread it is in the body. But if you could correct one misunderstanding about PEM in the medical community, what would it be for other doctors?
Well, just to play off of what you were using for the term, I know I'll just read this as a talking point. Not that I'm saying this should be a name, but certainly it falls in post-exertional immune metabolic excitotoxic gut microbial immune modulating HPA access modulating neuroglial immune dysautonomic debilitation with possible vascular endothelial and coagulation pathology, especially for the long COVID, gut wall barrier pathology, blood-brain barrier pathology, possible preload failure, maybe with pathogen or pathogen biomarker persistence reactivation with 4 phenotypes. Could you put those slides up for phenotypes, please?
Yeah, I can.
I'll just read off those phenotypes and for everybody to see if you fit in any of these things or these categories. Staci said she has 18. I have 4 for main ones for ME and 5 for long COVID. And I fully understand that these may be large groups and there might be subgroups. And that during the course of a person's life, this, what we call it, a phenotype, being a collection of symptoms may change over the course of the illness for the person, and it may even change over the course of a PEM experience, and that people can have one or more. I happen to have all 4. So there's this innate means the most immediate part of the 2 subgroups of immune reactions, interferent, inflammatory dominant, which people can see flu-like relapses, sore throat, lymph nodes that are enlarged, viral reactivity feeling, which I definitely get, and a strong delayed PEM. Another main category can be the immune metabolic loops and locks, and people may have disproportionate PEM, the cognitive energy failure, migraines, I have all this, sensory intolerance, tired but wired, that is very much me, and then an autonomic preload failure with orthostatic diseases, which I have, the cognitive PEM, exertion worsens orthostatic symptoms, heat intolerance, in fact, cold intolerance, heat intolerance, and then another main group with pain sensory amplification that I was talking about, with a higher gain and a lower dampening, the fibromyalgia type, widespread pain, which is absolutely horrible. Allodynia, meaning a normal stimulus that shouldn't cause pain causes pain because of that high gain turned up, sleep fragmentation, sensory hypersensitivity, and the next slide for long COVID main subgroups. The lining of the blood vessels can be activated, causing exertional intolerance, chest tightness, headaches, vascular related symptoms, sometimes the Raynaud phenomenon, where your hands, when they're cold, turn white, blue, and red, and the dysautonomia part that leads to a multitude of symptoms. A microvascular perfusion limitation, if the cells aren't getting oxygen for one reason or another. Metabolic processes are going to have to figure out another way of producing the ATP, high energy phosphate molecules, with disproportional shortness of breath, fatigue, with normal exercise, low reserve feeling, coagulation platelet activation. The lining of the blood vessels is very reactive with platelets. Platelets produce a lot of molecules that can cause immune reactions and blood clotting problems, with exertional worsening, neuropathic symptoms, the brain fog again. If I could have one thing that's improved in my symptoms, I'd love to have my brain back. Autonomic vascular coupling, the preload failure, with the orthostatic diseases, POTS, orthostatic hypotension, neurally mediated hypotension, again, the brain fog, symptom spikes with standing heat, eating meals, all these things that are normal activities of a person's prior life are can cause this cascade of symptoms. And then a vascular immune barrier, gut wall barrier, vascular neurovascular unit, blood-brain barrier interface problems with, again, the brain fog, headaches, migraine, horrible migraine, sleep disruption, the dysautonomia, and the GI flares. And so ask your question again, please, Clayton, after all that.
Yeah, if you could correct one major misunderstanding for other doctors,
yes,
how would you correct their misunderstanding about ME?
So I think from what I've actually experienced being a patient and talking to other doctors, doctors just want to help people. People go into medical field really being helpers. They want to help, but they don't know how to help. Well, help is comes in the form of getting people to be able to sleep. Doctors can do that. Dealing with pain, doctors can do that. Dealing with orthostatic processes, doctors can do that. But for doctors who see no evidence of disease on all the studies that they normally have, which I'm advocating or hypothesizing strongly that the answer to this is a combination of blood-borne problems, but also tissue cellular problems, which are not part of usual clinic studies. And when a doctor is presented with a patient that's sitting in front of them that looks well, but the doctor doesn't understand all that they've had to go through to get to the clinic and all the consequences, the doctor doesn't see them that evening or the next few days where the PEM really hits. It's hard for doctors to understand, and I'm not giving doctors a buy on this, but from their perspective, their journals aren't talking about this. The textbooks don't say anything. They didn't hear a single word about this in medical school, which is beginning to change. And so that delay of onset of symptoms, the doctor sees and doesn't understand the biology that's in that delay. They just see someone that looks healthy, go home and lead your life. But that is what I would want physicians to be very cautious, very, very cautious. Bend over 15 times before you decide that the person who's describing all these symptoms in this history is healthy.
Thank you. Yeah, it's instead of assuming, oh, you should just exercise or this is a psychological thing, doctors should validate more and recognize this isn't normal and how can I support you?
Mm-hmm.
And so part of this is we need additional research to help with understanding the condition and how to make changes in the body. And so I want to ask Staci, if you had unlimited research funding, what would you investigate? What research would you like to see done?
Oh, that's a great question. We measure the what really, really well. What is PEM? It's a metabolic problem, and it's objective. That used to be 20 years ago investigational, experimental, and now it's well accepted. The National Academy of Medicine. I just want to encourage everybody here for a minute. I want to give you a little message of hope in that the National Academy of Medicine says CPET can objectively measure PEM. That's what you take to your doctor. It's objective. It's metabolic. We can measure it. What I'd love to see is let's start looking at the cognitive aspects of PEM. Nobody's really unraveled that. I love the blood flow studies, the Visser and the Van Kampen. I think we need to look at blood flow to the head with both orthostatic stress as well as exercise stress. What is happening? What role does blood flow to the head play in those delayed symptoms of PEM? And I think that would be really exciting research and another objective component to add to it. So I think that's what we're looking to do next. And if we had unlimited funding, I think the second thing we'd love to look at is where are those PEM busters? You go into PEM, if we had some PEM busters, Clayton, we've talked about this. What's that emergency rescue kit that we can provide A, B, C, and D, and to research those things, not just have that clinical experience of here's what I use and this is what helps for some patients, but to be able to do this in a systematic way and get that information out there
Yeah,
because
to
there
stop
are things.
that before it
Yeah.
develops into.
Exactly. You feel that coming on, that first sign or symptom, that short-term PEM, and then you do this, this, and this, and it goes away. And this is happening. My clinicians are telling me that they have tools to help rescue them. Clayton has talked to me about some of his rescue tools. So, I want you to be hopeful that this isn't a life sentence, that we are getting on top of this. The American College of Sports Medicine now has a chapter on ME/CFS. This is the first time that it's taken 20 years to get there. 2-day CPET is in there. PEM is in there. Don't exercise is in there. So this is from a major medical organization, and now we just need to educate folks about it.
Absolutely. Yeah,
So
there's definitely.
education is also important. So lots to do yet, but we've also made lots of progress. So I want everybody to be hopeful out there.
Yeah, both of you have lived with ME/CFS for a long time, and so you've been able to see progress is speeding up these
It
last
is.
few years, and there's a lot
Can I
more
add
research.
to
Yeah,
that? Is that okay?
yeah,
So I definitely want people to take home that PEM is not fatigue, it's debilitation. That the delay of the delay of the onset is real biology. Don't be dissuaded by someone else that tells you otherwise. I want to echo the hope that Staci is relaying very much from the 30 years I've watched. Um, there are more clinicians, there are more research centers, and there are more articles on ME, and there's a whole bunch of articles on long COVID. Uh, that phenotyping of that I was going through is really important for clinical use and to advance research at a faster pace, because otherwise researchers just get confused with, well, who am I studying? And I encourage people to journal the good things that are in their life, just to really drill into us as patients, what is good, and to focus on the good, to focus on other people, and that you've seen that this is a very complex process. It takes research, it takes distribution of this ME expertise that Staci's Workwell Foundation has, and Bateman Horne is working on too, and to help ourselves, literally, I mean, Staci, thank you so much for the research that you do. Thank you, Clayton and BHC, for all the things that you do. And I support financially anyone else that can support financially. Please give to these two foundations and centers. It is helping ourselves.
thank you. And thank you so much for joining us today, for sharing your perspectives and insights after years of living with these conditions, and also helping in doing research and figuring out solutions for helping people. I know we didn't get to some of the questions that were in the chat, and so we will respond um, to those questions via email. Thank you for joining us. We hope to see you again for our next session on Wednesday, April 8th at 10 a.m., where we will dive deeper into post-exertional malaise and how to explain what PEM is to your healthcare providers. And then we'll send an email with the recording and associated resources at the end of the month to those who have subscribed to BHC emails. And please complete the brief survey that'll pop up on your screen. We look forward to seeing you next month. Thanks.
Thank you, Clayton. Thank you,
Thank
Staci.
you.
Thank you, everybody.